And welcome back to the trial of the nurse Lucy Letby. A reminder before we start today's video that Lucy Letby is facing 7 counts of murder and 13 of attempted murder. She has pleaded not guilty to all charges. The next witness to give evidence is Dr. Sarah Rylance. Dr. Rylance confirms she was employed at the Countess of Chester Hospital as a registrar in June 2015 and worked a long day shift on June 20th that day. She confirms she has the clinical notes for child D to hand. A reminder that due to reporting restrictions, none of the children in this case can be identified. Dr. Rylance says she does not believe she was present at the birth of child D. The details are recorded retrospectively that child D was born at 4:01 p.m. on June 20th. The note includes, quote, bleeped again as midwife not happy with her colour. She's not able to say, however, whether that was her being bleeped. Child D, quote, looked dusky and had poor respiratory efforts with initial oxygen saturations at 48%. Poor respiratory efforts at 7:30 p.m. The note adds, transferred to incubator. After being given breathing assistance via Neopuff, child D pinked up quickly and started regular resps. The prosecution asked for what child D would have been assessed as. Dr. Rylance replies, she responded well to the ventilation support she has been given. In relation to the blood gases, it's difficult to assess how that reflects on her clinical condition. The blood gases suggest child D had difficulties with breathing and metabolism, but Dr. Rylance said she would not use the blood gases alone to make a diagnosis, but take that into context with other readings and observations. Child D was transferred onto CPAP and an IV saline solution was administered. Child D was also started on triple lights as part of phototherapy to treat her jaundice symptoms. That was the maximum treatment level, Dr. Rylance tells the court. Dr. Rylance's notes also record for child D at 8 p.m. the baby girl was on CPAP, 40% oxygen and saturations 100%. Child D's heart sounds were, quote, normal with an OK pulse rate, and it was noted there were regular breathing efforts, but fairly shallow, and the abdomen was not distended. The plan was to continue CPAP and administer dextrose and repeat a blood gas test at 8:45 p.m. Dr. Rylance's notes at 8:20 p.m. record the parents were updated on child D's condition with likely sepsis, and she was receiving antibiotics to treat infection. The doctor tells the court child D's condition was at this point responding well to interventions and appeared to be stabilised on the CPAP and making respiratory efforts. Overall, I was happy with the progress she had made, but she needed to be closely monitored and assessed. A further entry is made on June 21st at 2 p.m. in the clinical notes. The entry records the insertion of a UAC and UVC into child D. The UVC was removed as it was only able to advance to 5 centimetres. Dr. Rylance says, quote, usually you are expected to advance it much further. It can be difficult and fiddly to do this procedure in newborn babies. The UAC was inserted to 20.5 centimetres but did not get a blood sample back. An X-ray review found it was advanced way too far and the route was not typical of a UAC. The UAC should follow a typical route, the court hears, and the line was pulled back to 9 centimetres. A blood gas reading was taken and the readings were much improved. A second X-ray showed the UAC position was, quote, better, but the route was still not typical. The much improved blood gas reading was, Dr. Rylance believes, a comparison with the previous blood gas reading. The UAC was actually a UVC and adjusted to be used as a UVC. The plan was to continue CPAP for child D and repeat a blood gas reading and try to sample UVC for various readings. A review is carried out at 7 p.m. on June 21st with presumed sepsis noted. A CRP reading of 1 is recorded, having previously been 6. Dr. Rylance commenting on those readings, quote, I wouldn't attach particular significance to it as both readings were low and would need to be taken in context with the baby's clinical condition and observations. Child D had been on CPAP all day, but in air and saturating well with no desaturations. The initial blood gases post-extubation at 9 a.m. were, quote, not good, so child D was put back on CPAP at 10:30 a.m. Dr. Rylance said child D had made good progress and her ventilation status was very satisfactory at the time she reviewed her. Under the heading sepsis, the CRP reading was 1, and child D had not had lumbar puncture yet. Such a test is done in clinically stable babies to test infection has not spread, the court hears. But child D was, quote, not stable enough for that to be carried out. Other observations were noted by Dr. Rylance that child D was, quote, responsive on handling with chest clear, regular resp effort, minimal recession, abdomen soft, not distended. The feet were quite purple, but Dr. Rylance says that would be as a result of frequent tests carried out. The court has previously heard heel prick tests would be done to get results such as blood gas readings. Dr. Rylance added, overall my observations were that she was stable and handling well and responding well to treatment she had received throughout the course of the day. Under, quote, impressions, Dr. Rylance noted, stable on CPAP, tried taking her off but resp effort became irregular and desaturated a few times, so put back on. Dr. Rylance said she would not have attached a lot of significance to this as it takes some babies some time to settle. She was obviously unwell when she came to the neonatal unit the previous evening. She needed a bit more time from the CPAP, having been ventilated and moving to breathing. If they don't seem to tolerate it well, you can just put them back on CPAP. She was heading in the right direction, she just needed a little support from the CPAP machine without added oxygen. The note added as part of the plan, quote, leave on CPAP, await CRP, leave UVC for now to allow sampling for gases, continue antibiotics. Dr. Rylance says she was happy with child D's clinical condition, having had a very satisfactory day and was improving in good colour, not needing oxygen support. She has shown good improvement from the condition when I first saw her on the neonatal unit the previous evening. Ben Myers, KC, for Letby's defence, is now asking Dr. Sarah Rylance questions. He says there were 2 instances of her examining child D. He said that at the end of the June 20th examination, she was, quote, happy with child D's progress. Would you agree she was at risk of complications? Dr. Rylance says child D had responded well to treatment, but the blood gases were not in a normal range, and that would require close observation. Mr. Myers points to child D having lost colour and floppy when in her father's arms moments after birth. Do you agree that is worrying at that stage? Dr. Rylance agrees the APGAR scores of 8 out of 10 and 9 out of 10 aren't relevant for 12 minutes later. Mr. Myers asks if the progress of child D is based on the reference point from the worrying signs just after birth. Dr. Rylance replies, my opinion of her at the end of the shift, my reference point is from when I first had contact with her on the neonatal unit, from when she required ventilation support. I wasn't involved at her birth, I can't comment on her condition at the time. My writing on the clinical notes is based on what I had been told. It's my summary, but not my observations, if that makes sense. Mr. Myers says, you will have known she started grunting in theatre, reviewed after 1.5 hours, quote, grunting but otherwise observations okay. Mr. Myers asks if grunting can refer to respiratory effort difficulties. Dr. Rylance replies, yes it can. Dr. Rylance says she is unable to recollect whether she saw child D prior to her neonatal unit admission, but does not believe she was involved in the review to bring her to the unit. She said, quote, from the point she came to the unit, these were my direct observations. Mr. Myers asks if Dr. Rylance reviewed child D at about 7:30 p.m. Mr. Myers asks, she presents as a baby who is seriously ill. Dr. Rylance replies, yes, at that point she was an unwell baby. Dr. Rylance says she believes the first time she reviewed child D was in a neonatal unit. Had she done so before, she would have noted that from a ward observation. The gases taken at that time show marked acidosis, Mr. Myers asks. Dr. Rylance agrees. Mr. Myers says, you explained to us these were abnormal and indicate difficulty with the respiratory system and metabolic components. Dr. Rylance replies, yes, that's correct. Mr. Myers says those readings are taking into account the clinical condition for child D. Dr. Rylance replies, yes. Mr. Myers asks, but at this stage, weighing up the clinical picture, it was not a good picture, was it? Dr. Rylance replied, no. Mr. Myers said at one point Dr. Rylance had referred to the examination as being, quote, normal, but there was quite a lot of child D being abnormal. Dr. Rylance says child D was, quote, not a healthy baby at this point in time. She says she is aware child D was later put onto a ventilator. Mr. Myers says infection is a leading cause in neonatal deaths and can develop very quickly. Dr. Rylance replies, it can. She continued, as a rule, antibiotics should be given to a neonatal baby. There are different guidelines on whether babies should receive antibiotics with clinical risk factors. When you have concerns, then you want the antibiotics as soon as possible. Mr. Myers says child D's mother had her waters break many hours before giving birth, and that child D was at birth floppy and at risk of collapse. Dr. Rylance agrees child D should have received antibiotics at this stage. She adds, this is reliant on someone else's documentation, and it is difficult to say precisely how child D was responding at that time. She says it would have been a good idea to start antibiotics as quickly as could be done, and that was done upon her arrival at the neonatal unit. Mr. Myers said, the reality is, from the point of view of collapse at 12 minutes, given everything we know, the plan would have been give antibiotics rapidly. Yes, I think so, she replied. Mr. Myers says child D was not given antibiotics until nearly 4 hours after birth at the neonatal unit. Dr. Rylance agrees that would be the case. There was a 4-hour delay in the delivery of the antibiotics after birth, is that correct? She replied, yes. You may not be responsible, but that falls below the standard of care for a newborn baby, doesn't it? Yes. The purpose of antibiotics is to treat and reduce the risk of infection. She replied, yes. Mr. Myers refers to the blood gas readings on the afternoon of June 21st. Dr. Rylance says there would have been a blood gas chart and the readings were presumably an improvement on what was previously taken. Dr. Rylance tells the court the intention was to insert a UVC and a UAC if it's possible to do so. The court hears the UAC inserted acted as a suitable UVC instead. Mr. Myers refers to the, quote, presumed sepsis CRP1. He says the CRP reading increases from CRP1 to CRP6 later that night. He says from those readings they cannot diagnose infection on their own. Dr. Rylance replies, yes. Mr. Myers refers to an attempt to take child D off CPAP by Dr. Rylance as noted, and an accompanying nursing note referring to the oxygen levels desaturating to the 80s. He says, quote, that is not a healthy state to be in, is it? She replied, it reflects she needed more respiratory support, but the fact she had moved on from ventilator support and needed no oxygen support suggested it was improving. Dr. Rylance added, by trying to take her off CPAP, we wouldn't have done that if she wasn't stable. She didn't tolerate it, so we put her back on. The improving clinical condition, Dr. Rylance says, was from child D arriving at the neonatal unit to her observation the following day. Mr. Myers says the, quote, satisfactory examination of child D was carried out while she was on CPAP. Dr. Rylance says a lumbar puncture is quite an invasive procedure, and there is a risk of that being carried out if a baby is still on breathing support. In child D's case, it was weighed up, and it was felt it was not needed to be done at that time. Mr. Myers said Dr. Rylance had identified sepsis and acidosis at various points, and during the time she was cared for, child D required breathing support. He says that when child D was taken off CPAP, she began deteriorating. Dr. Rylance agrees. The prosecution, led by Simon Driver, rises to clarify about the notes made for child D following birth. Quote, as of your last review on 7 p.m. on June 21st, what was your assessment of her at that stage? From what I documented, child D was stable, with minimal respiratory support and no additional oxygen support. In handling, she was responsive and making good progress and making good response to treatments over the previous 24 hours. She was not a healthy baby at that time due to still requiring CPAP, but clinically she was stable and making a lot of progress. The next witness, who cannot be named due to reporting restrictions, confirmed she was a neonatal unit nurse at the Countess of Chester Hospital in June 2015. She tells the court night shifts would be generally quieter in terms of staffing numbers, and there were no set rules on when they would take breaks. It would depend on workloads. When they were on breaks, another member of staff would be directed to cover for the designated baby. That role could be done by the shift leader. The nurse confirmed she was the designated nurse for 2 babies in room 2 on the night shift of June 21st. She said she cannot remember having any cause to be involved with child D on the early part of that night. A medicine chart is presented to the court showing the nurse was a co-signer for doses of medication for child D at 9:23 p.m. The nurse says her memory of child D's collapse at 1:30 a.m. is, quote, vague, but remembers her being stiff and having a rash on her abdomen. She says she does not remember whether she was in the room at the time of the collapse. She says from her statement, colleague Caroline Oakley, the designated nurse, was not present in the room at that time. She recalls child D's appearance. The baby girl was discoloured and stiff. The discoloration was like a mottled appearance. It was an odd rash. It was unusual. She said mottling would be blue and grey, whereas this was not that colour. She said it was a reddy brown colour, which was unusual, and this was found on child D's abdomen. The nurse says she wants to say she had seen this discoloured appearance again, but could not say whether that was before or after June 2015. Asked by the prosecution to clarify, she tells the court she had not seen that discoloured skin appearance in the years prior to that. The nurse remembers child D recovered quickly and was examined by Dr. Andrew Brunton. She says from her notes the rash had resolved by that point. The nurse added a similar event happened for child D where she desaturated. She does not remember the circumstances but believed it was similar where she was given treatment, reviewed and recovered. She said she didn't remember seeing child D, but would have done so as part of her shift. She said she didn't remember anything about the child's appearance or recovery. The nurse tells the court there was further desaturating for child D. She would have been notified to the room but does not recall how, and there was a call for a medical review. Full CPR was being carried out on child D by the time Dr. Brunton arrived in the room, the nurse tells the court. The nurse recalls the efforts made to resuscitate child D, which were made in established guidelines, and ultimately efforts were not successful. She recalls the parents were there at the time. After child D had died, she recalls having a conversation with Lucy Letby on the resuscitation drugs used. A chart advising dose levels for the drugs would usually be kept by the child, but this A4 chart, a laminated piece of paper, was missing. The nurse said that chart was missing, and resuscitation drugs were administered by calculating the doses with child D's weight and using her years of experience. The chart eventually turned up, the court hears, as it must have gone missing in the stress of everything. Lucy Letby asked the nurse how she knew what dose levels to give, and the nurse explained how she had done so. Mr. Myers, for Letby's defence, asked the nurse about workloads between June 2015 and June 2016. The nurse agrees there was a higher workload during that time, with an increased acuity overall in the patients arriving in the unit. Mr. Myers asks about the 14 babies being on the unit on the night of June 21st. He says ideally the shift leader would not be looking after babies on the unit for that shift. The nurse agrees. Mr. Myers said child D was being looked after by Caroline Oakley, who was in room 1, and another baby in room 2, and that goes against the guidelines. The nurse says, quote, "It's not what the guidelines say. However, the ITU guidelines are quite specific." The nurse says some babies in intensive care require different levels of care. Mr. Myers says, ideally child D would have had one-to-one care that night. The nurse replies, ideally, yes. Mr. Myers asks about child D's collapses that night. The nurse confirms resuscitation attempts were only required on the 3rd collapse. Mr. Myers asks about the rash, which the nurse described as mottled white circles with a reddy brown colour. He asks if that is what the nurse remembers from telling the police or from discussing it with colleagues. The nurse replies, "No, that is how I remember the rash." Mr. Myers asks if that is how she remembers the rash, as Reddy Brown was not in the police statement. The nurse agrees. She also says she cannot remember how long the rash lasted. The court is now hearing from Dr. Emily Thomas, who in June 2015 was working at the Countess of Chester Hospital. She remembers the night shift being busy on the children's ward and her colleague Dr. Andrew Brunton being called out to assist Child D. She recalls an unusual rash appearance at the 1:30 AM collapse with purple colouring around the abdomen. Dr. Thomas said she was in the middle of a septic screening in room 2 or 3 at the time of the third collapse. She said she believed Lucy Letby was the one who had called for help and recalled her being upset, saying what she recalled was, quote, "This is my second baby that this has happened to." She did not recall seeing a rash on Child D during the resuscitation attempts. The next witness, Elizabeth Marsh, was working a night shift on June 21st. She said on this shift she was looking after babies on the postnatal ward and babies on the neonatal unit. She said she saw Lucy Letby giving chest compressions to Child D at the time of her third collapse. She said she was not directly involved in the resuscitation attempts and was involved in the transcribing of the efforts, writing the notes on a paper towel. She said there was a short debrief at the end of that, but nothing more formal at that time. The court also heard from Dr. Thomas's statement there was a communication mix-up when Dr. Brunton was on the telephone to what he thought was an on-call consultant, but was actually one of the parents of Child A and B. By this time, Child A had died and Child B was being treated in the neonatal unit following a non-fatal collapse. Previously, the court heard the parents of Child A and B would be in very regular contact with the hospital throughout the night for an update on Child B's condition. Dr. Brunton was, quote, "mortified when he realised a communications error had been made."